my name is Stephen Robertson. I'm with the Permian Basin Petroleum Association. This is a webinar series that's been put on by PBPA jointly with OTA Compression. It's a series that OTA started and PBPA has jumped into and helped with to really try to get information out to our members about what's going on in the industry, what's going on in the community, in particular as the impacts of COVID-19 have impacted and affected operations. Today, we're going to be talking with a panelist on rural healthcare, something that is incredibly important to all of the members of the PBPA, because the Permian Basin is proud of the fact that we live where we work and our employees live where we work. And so impacts and changes to rural healthcare have huge consequences for our membership. On the panel, we were trying to cover both some New Mexico issues and some Texas issues, specifically as it impacts the Permian Basin, but just generally rural healthcare as well. I'm going to start kind of doing a small introduction, but let every one of our panelists introduce themselves a little bit more. First, we'll start off with Mike Miller, who works with PBPA and has for a decade, advocating for the industry, but also for healthcare. So Mike, why don't you give everybody a little bit of introduction on who you are?
Good morning, Stephen. Good morning, everyone. Again, Mike Miller. I live over here in Portales, New Mexico. Actually got in contact with PBPA through my healthcare work, as I work with and have worked with hospitals in Portales, Artesia, Lovington, Health Clinic in Eunice, and also a larger tertiary facility over in West Texas. So, and I've been involved in that field now for almost 20 years.
Thank you, Mike, and thank you for joining us this morning. Next, we've got Tom Banning, who is the CEO for Texas Academy of Family Physicians. Tom, why don't you tell everybody a little bit about yourself?
Great, thanks, Stephen. Yeah, Tom Banning. I'm based here in Austin. Our organization represents about 9,000 family physicians across the state, from the Panhandle to the border, from El Paso to Beaumont and everywhere in between. I've had the privilege when he was still lobbying, and I know he said he's retired, but working with Dan Hinkle for several years on some healthcare issues. And we spoke often about the critical role that the Permian Basin plays in the state of Texas, both in terms of the economic benefits that the state sees from the Permian Basin, but also some of the challenges. So I really appreciate you having me on the call today.
Absolutely, Tom. Thank you for joining us. And yeah, we're pleased to have Dan as part of our team that's been helping us with the past 2 years, and he helped us get us connected to you. And that's the great thing about the network that you can have in associations like ours, is you can find the right people to talk about the right topics. And so we're really appreciative of having you here today. Next, we'll talk with John Henderson, who's the president and CEO for Texas Organization of Rural and Community Health. John, why don't you tell everybody a little bit about yourself?
Yeah, thanks, Stephen, and good morning, everyone. TORCH is the acronym for the words that Stephen just conveyed, but I work for the 157 rural community hospitals in Texas. Same as Tom, they cover the entire geography of the state. Definition of rural in Texas is county population of 60,000 or less, so anyone that falls below that threshold is considered rural, and I work every day for rural community hospitals in Texas.
Thank you, John. And I think that one thing that everybody should feel pretty comfortable about when we talk about this topic is we've got a varied panel here. It's going to be able to give a lot of information. But one of the gentlemen that's on this panel that really sees the impacts of this on the front line is our last panelist that I'm going to introduce, and that's Dr. Tim Benton, who's the professor for family medicine and chairman of the Department of Community and Family Medicine with Texas Tech University Health Sciences Center out here in the Permian Basin. Dr. Benton has gotten to see probably a lot more of the impacts of COVID-19 up close than any of the rest of us would ever imagine. Dr. Benton, why don't you tell everybody a little bit about yourself?
Well, that's a pretty nice introduction there. So you covered most about me. A little interesting factoid, though, too, is I was a rural practicing physician before becoming an academic physician. I also now am very active in the community from my positions at Texas Tech, but also hold positions with Ector County as the health authority, and also at Medical Center Hospital in Odessa as interim chief medical officer. So have been very involved. Additionally, from my academic position, I run a rural residency training program that's spread over 8 counties of the Permian Basin. So I stay pretty active in local, regional activities with the docs. So would you like me to go on about some experiences of what's been happening out there, or you just want intros now, Stephen?
No, I think that'd be a great place to start if you want to just jump right in.
Okay. So, the physician practices have been really interestingly impacted through COVID. It's a bit of irony to me that a medical illness has created a lot of economic struggle within the practice of medicine. At first, we had stay-at-home orders and shutdowns, right? And so the volume of patients attending our practices and the hospitals really declined for several weeks. And some of that was probably public fear, as going to the physician's office, they might contract the virus, So volumes really decreased tremendously. And that, of course, leads to decreased revenue and increased strain on practices and physicians. The irony, too, though, is that worked well and kept the virus load down in our region. So it led us to open back up. And now as we've opened back up, there's more virus cycling back around. So practices are still strained, where we did have a slight increase in volume come back, but now it's sort of cycling back to decreased volume again. The other thing that perhaps hinders some access, hopefully not, because we're trying to supply this, but the Texas Medical Board has instructed that each physician-patient interaction must involve a mask. Both the provider and the patient must have a mask. So we're having to ask all of our patients before they come to bring a mask. If they can't, we try to give them one, but that maybe hinders some of the interaction and practice of medicine, which is a risk to our healthcare system if there's not good sustainability and viability of these practices. On the positive side, this has forced us to explore telemedicine more. Regulations have been relaxed, opening the door for varying platforms, as well as billing and how we operate telemedicine. That's forced us, old guys like me, to learn it and get better at it and be more accepting of it. So I think that's a positive note for the future. But I hope also moving into the future that it becomes, the relaxing of regulations can stay. I mean, hopefully our leadership, like Mr. Banning, can help us with the legislature and regulatory bodies to continue to relax some of the strain or some of the regulations on telemedicine that we had previously that sort of hindered us getting into that. However, telemedicine doesn't fully reimburse as well as regular visits either. So there's another regulatory consideration. It sounds perhaps a little strange to talk about strain on the workforce when volumes have decreased, but there are different strains. So that volume has added, the financial strain, as I explained, but also it's added new strains of some of these places in rural communities not being able to have the resources to care for COVID positive patients. And even one COVID positive patient can really change your operation. You know, it becomes, you know, you have to practice the isolation and contamination practices, and it just changes your whole operation of how you go about seeing patients and how you see non-infected patients alongside those. The resources are also strained in that it's difficult for some of these places to get adequate equipment. Some of our rural hospitals may not have ventilators or may have one ventilator. They have difficulty obtaining the PPE or protective equipment at times. I even recently heard a story from a family doc, I'll say southwest of me, who was reusing his N95 masks, and the way he was trying to decontaminate those is to put them in plastic bags and put them out in the sun. So, I mean, there is evidence that ultraviolet light will decontaminate, but maybe that's not the, you know, perfect way to do it. But there are resilient folks out there trying to do the best they can for their communities and for their patients. Something that we were just talking about earlier, you know, testing capabilities have been difficult to acquire in the rural areas as well. So it's kind of this double jeopardy picture of decreased revenue, but also that none of us could have really been prepared for such a pandemic and this type of an illness, and we weren't. Maybe some things to look forward to, like telemedicine. We, you know, I think we're all beginning to see the value of public health and population health, which is one of my big interests as a family physician, as a primary care physician. We know that people who seek primary care tend to be healthier, so you pick up illness earlier. Of course, I'm biased to family medicine, but family medicine does provide the majority of rural healthcare in the nation, and we're sort of the last specialty providing primary care. We're kind of the backbone, I guess, of the healthcare system. So I think this pandemic is showing us too the value and the need for keeping primary care and building our primary care resources. In our region, we are short primary care, and I think that extends over into New Mexico equally well. Mr. Miller may have some better stats than I do, but even in the Texas side of the Permian Basin, like Midland, for example, is short as many as 40 primary care physicians. So, you know, I think this pandemic has shown us the importance of some of these things, but also shown us where there's strain in our system and the importance of looking at legislative or whatever from this group ideas for sustaining our healthcare system into the future. So maybe I'll shut up there. How does that sound, and see what questions there may be?
No, I really appreciate that. I know everybody else does too, Dr. Benton. You know, one of the things that the PBPA has experienced throughout this time is so much interest from media on what's happening in the oil and gas industry specifically. But everything that I read when I talk to gentlemen like yourselves, and when I talk to other people in other industries in the United States, around the world, is that everyone is experiencing these impacts. Everyone is having economic downturns. It's not just our industry. And so while similar to what you were talking about with primary care, oil production can be seen as kind of the backbone of energy in the United States. What impacts us is also impacting everybody else. So many people talk about, well, is this downturn different than others? Well, we've never seen negative pricing before. We've never had a downturn in the oil and gas industry that didn't benefit industrial development someplace else because now they could get energy cheaper. And so just in those two ways alone, this is different. But Tom, Dr. Benton gave us a good kind of rundown specifically on some things that he's seen out here in the Permian Basin. is what we've seen on the economic side similar on the healthcare side? Is this impacting rural healthcare everywhere across the state, or is it kind of specific to certain areas?
Yeah, it's affecting everything, everywhere, and everybody differently. If you think back, this disease has been with us for 5 months now. And there's a reason it's called a coronavirus. It's because it's novel. It's something we haven't seen. We don't have antibodies for it in our systems. We don't have, tests. Well, we didn't have tests that were really designed to figure out if you were at risk or you had the COVID-19 until you were symptomatic. So, for the last 5 months, we've been learning a lot, and I think we still have a lot to learn. But if you think back about, really when it hit Texas, I kind of think of COVID-19 in stages. The first stage is, oh boy, it's coming. We better be prepared for it. We need to have PPE. And most primary care physicians, I would suggest most rural hospitals, don't stock up on things that they're not going to use. Family physicians, certainly in rural areas, typically don't need massive amounts of N95 masks or gowns or gloves or other protective gear. And it became very apparent very quickly that our PPE supply chain was broken. We rely heavily on China to bring in those supplies. And there was a choke point in China because that's where the virus was taking hold. So supplies of PPE coming in was a huge problem on the front end of this pandemic, which really slowed physicians and hospitals' ability or willingness to screen for and test for COVID-19. Sort of the next iteration was access to testing. You were having concerned people call, but by and large, community physicians didn't have access to testing capabilities. So we were funneling those patients to the local public health authorities. And the local public health labs were originally not designed to screen for massive amounts of things like COVID-19. And they also have they continue to have to do things for STD, for other public health issues. So they were overrun and overwhelmed. Finally, a couple of weeks, a month went by, maybe it was a little bit longer than that, and testing in the private labs, private physicians came online. Sort of the next iteration was the stay-at-home orders, which was a gut punch to practices around the country where patients were staying at home. They weren't going to physicians' offices. So physicians' offices are very much like any other business. Their business model is dependent upon what's called fee-for-service. It's very transactional. We've argued for a while that it doesn't really reward or reflect the value of what primary care does, but the way in which you have to bill for services is when a patient is physically in the office, that there is a ICD-10 code that you could make a diagnosis, code for that service, and bill for it. Well, when volume drops 50 to 70%, that means your revenue is dropping 50 to 70%. So once practices started seeing that, they transitioned or pivoted quickly to telemedicine. As Dr. Benton mentioned, telemedicine can be a really good way of extending practice, of taking care of patients, existing patients, especially those that have chronic problems that may need to connect with a doctor. But there are really two issues. One's a technological one, and that is a very small percentage of physicians have really ramped up telemedicine use because there was no payment for it by and large. and you had to have HIPAA compliant technological platforms that most doctors didn't have. And on the other side of the phone or the video chat, you had to have a patient that was technologically capable and willing to use it. So we saw a lot of certainly elderly patients that did not want to hop on a Zoom call and talk to their physician about the problem that they're dealing with because they were afraid they'd get hacked by Russia or by somebody having a very private conversation. So the relaxation of both some Medicare regulations and state level regulations really allowed physicians to utilize telemedicine in a way that was not available to them pre-pandemic. There was also some changes in reimbursement or payment that allowed for compensation for using telemedicine. So now you fast forward to where we are today. So we got through those 3 stages. Things were looking good. We held down the curve. And then we began opening up the economy again, which we needed to do. I think that the challenge was we also needed 3 other things to happen that didn't happen. And I think that it's created a problem that we're going to be digging out of for a long time. And that is we needed trust in the government and the government's institutions. We needed trust in science, and we needed trust in the media. To amplify the voice of government and science, and those 3 things didn't happen. And you're still seeing it today, where wearing a mask has become a partisan issue, and it makes no sense, and it's really hard to bend that curve down. So, kind of going forward, I think that our challenge is going to be really educating the public and our patients about what needs to happen if you want to get back to work safely, if you want to open up the economy. And I think that that's probably also some of the things that employers are struggling with as well. They want to have a safe environment for their employees, but there's got to be some personal responsibility that comes along with that, and acknowledgement that we're willing to do this for the greater good. When I wear a mask, I'm not protecting myself from you, I'm protecting you from me. And because the way in which this disease manifests itself, I could be negative today and positive tomorrow. And we just don't know from a viral load standpoint when I could be most infectious and harm somebody. And that's just the reality of what we're dealing with. And remember, all of these things, and I hope we can kind of come back to this, all of these things are going to result in legislative changes, I hope, for a positive standpoint, as well as some budgetary issues that we're going to have to deal with because of how long we shut the economy down.
Well, thank you, Tom. And it's definitely something that I want Mike to chime in here in a little bit and talk about some of the things that have already maybe happened on the New Mexico side. But John, I want to see if you'll jump in there first and talk about we've heard from Dr. Benton and Tom on their different perspectives. What's the perspective you have on this? What are you hearing from your members about what's going on and how it's impacting their ability to function and really survive?
Yeah, and I'll leave some time for Mike. And I don't disagree with anything Dr. Benton or Tom have laid out in terms of the conversation. What we try to remind people of is that rural hospitals were hurting before the pandemic. 44% of rural Texas hospitals had negative operating margins in 2019, and it's hard to survive when you can't net even. We count 27 rural hospital closures in Texas since 2010, which is double any other state. But thankfully, none of those have been west of Abilene. So far West Texas hasn't been impacted by that. And then rural hospitals specifically during the pandemic have been stretched, either because they have cases and struggle with PPE, as Tom said, there's no stockpile in far West Texas, and they have trouble with staffing and equipment. We talk about 13,000 available beds statewide, but I think it's more, useful to think of Texas as 5 or 6 different states. We count 5,000 available beds in rural Texas, but rural hospitals don't staff for anywhere near that level. So if we really do have a surge or flare up, as we experienced up in Moore County, Dumas, Texas, and down in El Campo, and more recently, I think Crane had a flare up related to a nursing home, and Mount Pleasant had a flare up related to a meat processing plant. You know, that can really put a strain on a rural hospital quickly. Dr. Benton mentioned vent capacity. We actually count 600 vents, rural vents statewide, which you think is an average of 4 per hospital. But the truth is the hospital in Uvalde has 60, and the hospitals in Iran and Ballinger and El Dorado don't have any. So that can be a challenge, especially when your urban hospitals fill up and are using their equipment. So, you know, 4 walls and a bed doesn't make a hospital capacity if you can't staff it and you don't have the equipment you need. But those are the people that are dealing with it. Even those that aren't feeling the surge are feeling the financial and operational strain of, you know, as Tom said, the stay-at-home order, the suspension of elective surgeries. Rural hospital CEOs tell me that 50 to 75% of their revenue is either, you know, clinic visits or elective procedures and surgeries. And in rural Texas, elective doesn't mean unnecessary. You know, it means that it can be scheduled or deferred. I think that healthcare workers are undeniably the heroes in all of this. Their courage and selflessness have been on display every day, even when we're struggling to keep them safe with masks and gloves and gowns. Specific to the PPE situation in rural Texas, most rural hospital CEOs are telling me that they're okay with regard to masks and gloves and maybe not gowns. They're still struggling to find gowns, but hand sanitizer. And what they're feeling more urgently recently is the need for nasal swabs and test kits and things of that nature. But even though the healthcare workers, I think, have done an admirable job, the healthcare system hasn't performed as well. And when you consider that we spend $4 trillion a year on healthcare in the United States, I think it's fair to say we should expect better results than what we've seen. So as Tom mentioned, our system will change. It'll just have to, not just with the innovation related to telemedicine, which we view as a game changer in rural Texas when it comes to access to care, but in terms of coverage and health outcomes as well. And, you know, even though I don't know a lot about the Permian Basin specifically, you know, most rural community hospitals are structured as hospital districts with taxing authority and do things like hospital and clinic and EMS care. Most of those do that independently. So I think it's a stretch to call our approach to healthcare a system currently, but we'll be working towards that in the days and years to come and into the legislative session, which I know we're going to talk about. So I'll pause there, make sure that Mike gets to cover anything that he wants, and then maybe we can circle back.
Absolutely, yeah. I want everybody to be ready to talk about what actual changes we could see maybe in the legislature. But Mike, that's a great segue into kind of bringing you in, because one of the things New Mexico has already had to do is have a special legislative session this summer to deal with some of the changes that have impacted them economically. But we've heard from Dr. Benton and Tom and John really on the Texas perspective, how it's impacted rural hospitals. But in particular, one thing that they mentioned, and I think it was Tom specifically that brought it up, was that idea of the opening back up of the economies. Well, New Mexico has done it a little bit different than Texas has, but has there really been a noticeable difference in New Mexico? Is there a way or is there any mechanism set up that helps New Mexico a little bit more than Texas, or makes things a little bit more different on that side of the border?
Well, thanks, Stephen. You know, first of all, what I would say about New Mexico is what everyone has said is the same impacts that we've had here in Southeast New Mexico on our small hospitals and clinics. I mean, and the lifeblood of all of that is just what was brought up: the elective procedures, the access to the clinics, and those sorts of things. So we felt the strain as everyone else has. I was visiting with the CEO about probably a month ago, that she was worried that she wasn't going to be able to make some payroll, and it was mainly because of, you know, they live and breathe on those ancillary procedures that take place. I'm going to throw out a question, if you don't mind, Stephen, and then maybe I'll get to what you were talking about. But I've heard a lot from everyone on the panel so far with regard to telemedicine. I know that I've had some experience down in far southeast New Mexico working with some of our providers down there, and we were trying to build some platforms. Are you running into problems in some of your more rural areas, like we refer to sometimes as frontier areas, that although that sounds like a good idea, there's just not the bandwidth to function with telemedicine? I mean, not to mention some of the other problems, but I mean, there's places that, you know, they don't even have 3G on their phones, and so we've run into several problems down in South Lee County with access to broadband. And I'd like to just throw that out there, because I think that's an important aspect when we talk about telemedicine all the time. We're sitting here on a Zoom and probably have some, you know, decent bandwidth to carry this out, but there are places in rural southeast New Mexico that this is not even possible. So is it okay if I ask that question, Stephen?
Yeah, absolutely. Dr. Ben, you might be the best one to try to field that off the bat, and we'll see if Tom or John have anything to add.
Okay, sure. Yeah, so that is a struggle out here. There are parts throughout the region of West Texas that are difficult to get internet access. You know, I have been working with the Permian Strategic Partnership for quite a while, and we've been talking about developing telemedicine networks across the region, and that is a challenge, you know, particularly when you get away from the cities, the communities, you know, and you get out into the real frontier, I guess, as you use the term. But, you know, each local unit, I think, does okay with their internet access to their office. But if you're talking about, you know, bringing broader access to care into the city, right, or into the higher population centers where you may have multi-specialty availability, that becomes a little more difficult. But also, I think difficulty out there, even within their sort of local municipalities, then you have to get technologies like Zoom and these other platforms that may not be readily available, and then also costly. So it's more than even bandwidth. So.
Yeah, I would just add that, you know, last session we passed a bill that created a gubernatorial broadband entity that I believe was appointed. I want to say it was maybe February. So, you know, there's an acknowledgement that, you know, we've got issues if we want to, you know, take rural Texas into the 21st century, and we were trying to get ahead of it. Clearly, we missed the window, but you know, that broadband group is still meeting, is going to come up with recommendations. I'm sure John, I think might even be participating on it.
I'm not participating on it, Tom, but that Governor's Broadband Council actually met the week before last, and I got a report on it. Specific to rural Texas hospitals, you know, I'm aware of 2 or 3 in deep East Texas that still don't have fiber to their building, but most rural hospitals and school districts actually do. The problem with that last mile and broadband is individuals, and not just their access, but whether they can afford it and use it. You know, when ISPs report to the FCC, if they have anyone in a county with high speed, they mark that county as covered. But the example that came out of the last Governor's Broadband Council was from Baylor County, which is Seymour, Texas. The report showed that 98% of the county had access to high-speed internet, But Microsoft, who actually has more accurate usage report, shows that only 2% of the population uses it. And so when you're talking, rural hospitals have been, doing teleradiology for MRIs and CT scans for 15 years. We don't tend to think of that as telemedicine, but it is, and they have the bandwidth generally to facilitate a conversation from a rural clinic or hospital to a specialty physician practice without any trouble. The problem is if you're an individual in Marathon, Texas, trying to connect to a family practice physician in Fort Stockton, and you don't have sufficient fiber or bandwidth. That's the challenge when it comes to the last mile, in my mind.
And I'd say that the uniformity of system, which I think was something that Dr. Benton brought up, is something that we even as a trade association, when we're not trying to deal with life or death situations, have dealt with. Different people want to use different platforms, Zoom, Microsoft Teams, whatever it is that might be out there that somebody wants to use. And yeah, if you are somebody on the other end of the call trying to get help for yourself, and you're getting told by somebody at the hospital or physician's office, you need to download this app and install it before we can talk to you. That's not the most comforting response to be able to receive when you're trying to get help. So I can definitely see how that's an issue. Mike, has there been anything on the New Mexico side, like that effort that Tom and John were talking about, to try to put together a council to really review and figure out where broadband's really going and how to get it out to the places where it's needed?
There has been, Stephen, even at the end of the Martinez administration, and now bringing it into the, it was a big focus in Governor Lujan Grisham's first legislative session, and it continues to be, and pretty much the same as what John and Tim were talking about. Of course, when you look at New Mexico, we think of Southeast New Mexico, but then you got Northwest New Mexico, and you talk about frontier. It is extremely frontier. There are people out there that don't have electricity yet, so it's a big challenge here in New Mexico.
Stephen, I'm not catching you if you're.
Yeah, sorry about that. Mike, going back to that original question that I had asked you, what other differences are you seeing maybe on the New Mexico side? You and I talked a little bit about, well, it's not an extreme difference. There is a little bit of difference in the way that hospitals are funded in New Mexico than the way they are in Texas. And also, if you can, comment on anything that may have happened during the special session that could hinder or help any of these issues going forward.
Well, one of the issues, and I think we talked a little bit about this, and John, you mentioned that you have a similar program over there in Texas, but we have a what is called a safety net care pool that can funnel money into our rural hospitals, and the funding formula favors the rural hospitals, the smaller bed hospitals, to help them, and it's run through the Medicaid program. And it can be very significant in especially these times, in that there is some cash flow coming in, and it's based on uncompensated care from the previous year, and so that's been a little helpful. And again, most of our hospitals here in Southeast New Mexico are hospital districts, and they're so they have taxing authority, and that's how healthcare and the oil and gas industry get tied together in Southeast New Mexico, because through this taxing authority, most of them receive ad valorem tax from the oil and gas industry. I mentioned Artesia, Lovington, Eunice, small clinic in Jal, which is very helpful in helping them maintain and provide services that otherwise they couldn't afford to do. Now, you ask about the legislative session. We were facing, in our fiscal year ended yesterday, June 30. New fiscal year started today. And so the legislature had to meet in special session a week ago. I guess it's been 2 weeks ago. There was about a $500 million hole in the budget that ended yesterday. There's about a $1.5 billion, I'm sorry, with a B, and it could get larger, hole moving forward into the 21 budget. And so they met to do some solvency. One of the things that affects healthcare is they did some sanding on budgets. And the way I read it, without some of the federal funding, the plan then would be they'll cut our Medicaid budget by 32 million, and with our nearly 3-to-1 match, that's that 32 is 3 times that amount that we'd lose the funding for these programs like the safety net care pool and those sorts of things. So
yeah, that's pretty significant, and that's something that all governments are going to have to face. And the Texas legislature, which convenes again starting in January of 2021, is going to have a lot of questions to have to answer and try to figure out. John, I think I'm going to start with you because I know that you might have to leave us here in a few minutes, so I just want to make sure you could jump in there. From the rural healthcare side of things specifically, what are you guys going to kind of be looking at as the legislature rolls back into session and seeing what can you really try to do to help your members and help rural healthcare?
Well, the 2021 or 87th state legislative session is going to be brutal. There's no getting around that. I've seen estimates as much, I guess Mike mentioned $1.5 billion problem. I've seen $40 billion shortfall estimates for Texas. Session was supposed to be about redistricting, but now it's going to be more than just sanding to try to pass a balanced budget. In Texas, and Mike mentioned this, for rural hospitals, it's basically going to be about Medicaid rates. We had legislation last session that required the state of Texas to pay rural hospitals Medicaid cost, but it wasn't fully funded. We had hoped to go back and try to fill that bucket, but anything other than cuts is going to be a challenge for everybody in healthcare in the next legislative session. And then with regard to telemedicine, it was an emerging, innovative trend prior to the pandemic. Now there's just no going back. People are not going to sit in a crowded waiting room and allow other people to cough on them if they don't have to. And so we see some of the allowances in telemedicine related to the emergency orders, like distant site, which is a technical term for downstream from like a rural health clinic instead of upstream to a specialty care physician. We hope to see that temporary allowance made permanent so that we can continue to innovate. And telemedicine has really been catapulted forward as the way we're going to receive care for most things that aren't procedural going forward. So those are our legislative priorities heading into the session, but we expect it to be a real battle.
Dr. Benton, from just putting on your academic hat and those types of institutions, the institutions that help to get the new medical professionals out into the world, what are you either focused on or the most nervous about maybe as you see us moving forward with the funding streams, and what could the impacts be to an organization like Texas Tech University Health Science Center?
Well, I think a real key, to borrow a term from your industry, the real key to the primary care pipeline is trying to train those physicians at those sites. We know from past experiences and from studies that a person who does a residency in a particular spot, they're more apt to stay at that spot long term in practice after they finish their training. But the strains on the system financially make it more difficult to provide financial support for those residents training. Now, Texas has been fantastic in leading the way with primary care expansion grants, of which I tap into 24 positions of that. And I hope going forward into the legislature and the struggles that are coming, I had no idea this big a number as John just put out. I hope that Texas will continue to fund those, and I think that's important to our infrastructure going forward. The telemedicine obviously is something we're rapidly exploring and trying to venture out, and that's part of, I think, from the academic center and part of my goal in building this sort of network of training sites, that also can be a network linking telemedicine. So I'm very big proponent of driving those initiatives forward as well.
Tom, with family physicians and primary care being so incredibly important to help reduce costs on the medical system later on, is that something that you guys are really focused on as you're moving forward, trying to make sure that people keep their eye on that ball, that we can't cut out our legs from underneath us? We've got to continue to focus on that, or do you have bigger fish kind of to fry out there? Anything else you're focused on?
Well, there's always big fish to fry. Kind of where our focus is on, one, the House appointed a select committee on healthcare cost that was intended to do exactly what you just described, really look at healthcare cost trends, what are driving those trends, proven solutions to reduce healthcare cost, which would, by definition or should reduce health insurance premiums to make it more affordable for employers to buy insurance coverage. Kind of the areas so it's all wrapped together. But so the areas that we're really focusing on, in no particular order, is payment reform. And again, if you think about what COVID-19 has exposed in the failure of our fee-for-service system, it doesn't capture the value of what a family doctor or a primary care doctor can provide their patient in that continuity. It's just not rewarded under a transactional fee-for-service environment. So can we begin to accelerate toward value, or accelerate toward total cost of care? And when you think about Texas, the teachers' retirement system is by far the largest insurer, self-insured insurer in the state of Texas. They cover 750,000 retired teachers or practicing teachers. You include ERS, the Employees Retirement System, there's another 250,000 Texans. So we've got opportunities to look at state payment plans as well as Medicaid to evolving our payment system around something that would be better than what we have today and hopefully lower total cost of care. At the same time, we need to look at coverage expansion. Texas currently has, north of 5 million, 18% of our population uninsured, and that's pre-pandemic. When you look at the number of people that have been furloughed or laid off or maybe unemployed for the long term, there are some research papers out there that are projecting somewhere between 1.1 and 1.5 million additional Texans being uninsured, and that's just not a sustainable position for hospitals, for doctors to be in, because if you're uninsured, and you have a healthcare problem, either you're going to delay that problem, it's going to become worse and thus more costly, or you're going to put yourself in financial bankruptcy. So, whether that's some sort of Medicaid expansion where we can utilize a 9-to-1 federal match, or some other strategies that John and I are working on that are specific to rural areas, that's got to be part of the conversation. Telemedicine, for a long time we fought about what telemedicine, can do from a technological standpoint. Now we're talking about what it should do and how to best integrate that into both training and just workflow into practices. But that's going to be a big component, and that also ties back to the payment piece, because if you make telemedicine a fee-for-service event, you can really see utilization increase, which could drive cost. If you put it into a different payment methodology where it's bundled into a per member per month, then it really unburdens the physician from having to focus on generating a bill, and just allows them to use their professional discretion on how they want to care for their patient, whether that's in person, whether that's virtually, whether that's at the patient's home. So it frees them up to make those decisions. As was mentioned, we got a real budget shortfall coming in 2011. The last time we went through something similar, funding for our health-related institutions and our pipeline funding, including our physician education loan repayment program that puts 250 to 300 doctors into rural and underserved communities each year and helps pay off their indebtedness to medical school, was cut by, I want to say the family medicine training was cut by almost 80%. The loan repayment was zeroed out for a year. That's just a real choke point on workforce development that we can't afford to do because of the long-term ramifications that it has. I mean, when you train a doctor, you're not training them 1 year. It's a 3-year investment, and we're running on a 2-year budget cycle. So programs like Tim's have made that investment and can ill afford to absorb a cut at a time that when revenue is down because of their ability to bill for services. The last one, and Tim mentioned this earlier, is better integration of public health into primary care. There's a lot of conversations going on right now about contact tracing, about how if somebody tests positive, can we reach out to people that individual has come into contact with? We're hiring third-party entities to pick up the phone and call these individuals. Well, there's some real privacy issues. There's, people just, are like, I don't know who you are. I don't want to talk to you. Well, what if we integrated contact tracing into a physician's practice? So rather than having a stranger call you, it was somebody from Dr. Benton's office that and bundle that payment into a global payment that would go to that practice. So that practice would then be responsible for doing the contact tracing. They've got the administrative staff, they've got the clinical staff that can do it. And then having really the technical piece where there's a standardized or centralized data reporting place like our state's MTRAC or our prescription drug monitoring program, where doctors don't have to go to 8 different systems to report information, whether that's on COVID-19 positivity rates or contact tracing information. That's sort of the goal that we're going to be building toward. And we've actually created what's called what we've dubbed the Marshall Plan for primary care. So, post World War II, when General George Marshall really came up with a guide for how to rebuild Europe. I mean, that's kind of what we're talking about in a big picture. It's not going to happen overnight. It's going to be a 5 to 10 year investment, but there's no better time than right now to really reimagine what our healthcare system should look like to deliver better outcomes at lower cost that make physicians happy, that make patients happy, and that it actually puts value behind what employers are buying.
And that really winds into kind of the last question I have, and I was going to see if anybody in the audience, any of the attendees, if you did want to send in a question, you can use the Q&A to do that. We haven't received one so far, but if you're interested and you just hadn't done it, then you can try to submit something now, and we can try to get to it. We are going to try to wrap this up by 11:30. And so the last question that I had, and John, I might throw this to you first, just because I know that, again, you might have to leave us in a few minutes, is really on the practical side. We've talked a lot about the impacts to the medical community and a little bit about how that could impact service to those trying to utilize the community, but specifically for PBPA members, for companies out there that are trying to figure out, how do we get people back to work? What do we need to keep an eye on in getting people back to work? How are our employees and their families going to be impacted by all the variety of issues that are out there? What should those members know, or what's the last thing they should maybe take away from this conversation on how to deal with these changes to rural healthcare going forward?
That's a tough question and not necessarily my area of expertise, but even though the last 100 days or so have been terrible, I fear that the next 100 days are going to be similar or worse for most areas of Texas. And, all the things we've learned about virtual work and Zoom meetings are going to continue for the foreseeable future. the challenges related to childcare specifically as you try to bring single moms or young families back to work are going to be exacerbated, and people are worn out already, but we're going to have to ask them to stretch and continue to do more. So for employers, not necessarily healthcare employers, it's just going to require an awareness and sensitivity to those issues as we try to work our way back to normal and figure out this balancing act that I have no envy for the governor of Texas right now, trying to figure out how to manage that push and pull between the pandemic and the economy. But they're near impossible choices that I think just need to be made with a lot of grace.
Dr. Benton, anything to add on to that? Anything else?
No, I would say that is a tough question. And it's particularly tough out here for us because, I think we did a great job with the shutdown early and flattening the curve, as you will, but maybe to some extent is mistimed because now the COVID is blossoming even bigger. So it puts that second strain, as John was talking about, on the economy for another 100 days. So it is going to be difficult to figure out how do we get back. I would encourage us to wear masks and stay socially distant, and we can learn to work around this.
Tom or Mike, anything else to kind of add? Any final takeaways?
No, I think you're just going to need to be patient. We're learning more every day about the virus. There are new therapeutics that are coming online. I'm going to leave on a hopeful note and say that hopefully the fall's flu season is not as bad as it could be. And we can manage through. What I tell our members is, think in terms of, a 120-day financial plan or 90-day financial plan. I mean, you just need to be nimble and flexible because things on the ground change, and they're changing quickly. It could be good, it could be bad. We just don't know.
Mike, what about you? Anything last to take away?
Like I said, somebody, maybe it was John that mentioned it's patience. It's going to take patience, and as Dr. Benton said, it's a new world out there with social distancing and masks, and if we want to start working back to normal, we have to participate that way. And
yeah, and I think that it's something to kind of my last comments, and thank you all for being part of this panel to try to put a little positive light on everything, is that while we do have some extreme situations and some changes in our economy and our healthcare system that are unprecedented, we've got a lot of people that are committed to making things better. We've got a lot of people, some of the gentlemen on this call, men and women out in the medical community and men and women in the oil and gas industry that are committed to helping to improve what's going on. But it is going to take time. As we've said today on this call, there's a lot of things that are still being figured out, and we don't really know what necessarily tomorrow is going to look like. So that ability to be flexible is incredibly important, as so many oil and gas operators have had to learn with production levels. So it's not necessarily something different than what they've had to do so far, but it might be in a different area. Being more patient with your employees, trying to understand the challenges going on maybe at home or with childcare are still existing. And I think folks know that, but it's good to get a reminder of that. Gentlemen, I really appreciate you joining us today. I appreciate all of those that logged into this webinar series. We do try to get some good information out to you on really valuable topics. If you have any recommendations on another topic that you'd like to hear, please let us know. Reach out to Grant with OTA or me with PBPA and just shoot us a note and say, hey, I think this is a big issue that we need to talk about. Thank you again for joining us today. Hopefully you've learned something that can help you in your life. If not, worry you a little bit more about everything that's going on that you didn't really know about it. So many people, I think that healthcare might be doing decent right now because they've got an influx of patients from COVID-19. But that's really not the case at all. And for those that are in the trenches, they realize that it's not just caring for those patients, it's all the other patients that have other illnesses and diseases that they still have to try to care for and in a different way than they ever have before. So be patient with them as well. Thank you everybody for joining us today, and we will see you next time. Thank you guys.